panelists. Anything written in the chat box will have your name associated with it. All questions should be asked in the Q&A box on the top bar of your screen, which may be submitted anonymously or with your name attached. Questions will be answered at the end of the presentation. As a reminder, we are recording this event to be made available in the next few days on the Impact Program Cancer Care CSC site. Julie Goldstein, one of our Impact Program navigators, will be discussing today's topic with additional information about our program from our Impact Program leader, Kelly Nickelbein. Julie, thank you for joining us today.
Hi, everybody, and thank you for that introduction, Jillian. Again, my name is Julie, and I will be presenting on behalf of the Impact Program today. We have a pretty action-packed afternoon planned with our goals of what we hope to cover. First, we're just going to start off talking about the endocrine system in general to give you some background about where the endocrine system is and how it works. Then we'll talk more about types of tumors we can see in the endocrine system as far as where they may occur, who may be at risk for endocrine tumors, how they're diagnosed. And then at the end, we'll end with a discussion of inherited endocrine systems, focusing on when it might be helpful to have a family genetics evaluation. So again, lots to cover, but we'll get through it. Again, before we get into the nuts and bolts of today's discussion, I wanted to start with a basic overview of the endocrine system. So the endocrine system, as you may know, is a network of many glands spread throughout the body, and these glands make different types of hormones. Hormones are the chemical messengers that travel through our bloodstream and tell different parts of the body what to do. Often these hormones are telling our body to do automatic functions that we don't even think about. So they really are in control of a lot of everyday things that go on in the body. Things like metabolism, blood pressure, body temperature, stress response, growth, reproduction. That's just a few of the functions that are controlled by hormones made through the endocrine system. As I mentioned, endocrine glands are spread throughout the body. Today, we're going to focus on 4 main glands. Otherwise, I think we would be here all day. Those glands that we'll be talking about are the thyroid gland, the adrenal glands, the parathyroid gland, and the pituitary gland. Okay. To talk more about what an endocrine tumor is, again, just to give you a little bit of a background before we get into the nuts and bolts. So a tumor in general, regardless of where it is in the body, is really just a word to describe an abnormal growth of cells. Some tumors can be benign, meaning that they aren't cancerous and they don't have the potential to spread to other parts of the body. When we talk about endocrine tumors, though, benign, again, can mean not cancerous, but that doesn't necessarily mean they don't cause problems. We know that benign tumors in the endocrine system may cause problems if they produce too much hormone or if they press on nearby organs. We'll get more into that as we go on. In addition, just like any other tumor in the endocrine system, tumors can also be malignant, and that means that they're cancerous and they have the potential to spread to other parts of the body. As we talk about the different glands and the different types of tumors that we can see in these glands, you will notice probably a common theme that there is good news. Many times endocrine tumors are benign or slow growing and really can be treated successfully. All right, so let's get into it. This is the first gland we're going to be talking about today, which is the thyroid gland. You can see it looks just like a butterfly, and it's located in the lower front of your neck. So this is an important gland for, again, body functions we don't even think about, ranging from metabolism, body temperature, heart rate. Those are mainly controlled by the hormones T3 and T4, which are made in the thyroid. So if you've ever had routine blood work done at your primary care physician, sometimes they do this T3 and T4. That's what those are. Those are thyroid hormones. There are several different types of thyroid cancer. So the growths that we're going to be talking about in the thyroid today are those that are cancerous or malignant. I'd like to point out papillary thyroid cancer because this is the most common. You can see 85% of the time if somebody has thyroid cancer, it's going to be papillary thyroid, which is a good thing because we know it tends to grow slowly and is usually very treatable. I also wanted to point out on this slide medullary thyroid cancer because we're going to be focusing on that a bit later. Fortunately, it's rare. We see it in less than 5% of thyroid cancer cases, but it sticks out to us because about 25% of the time, or 1 in every 4 medullary thyroid cancer is inherited, meaning it's caused by a syndrome running through the family. So you might be asking, well, how do I know if what are the signs that I should be looking out for to indicate that I might have thyroid cancer? And the answer is actually most of the time, particularly if it's early on in its development, thyroid cancers don't cause symptoms. What I always find to be really interesting too is sometimes or most times the blood work, the T3 and T4 hormones are normal in somebody who has a thyroid cancer. So that means that if the hormones aren't altered, you might not really have any symptoms. If somebody does have a symptom of thyroid cancer, it tends to be more something like pain in the front of the neck, difficulty swallowing or breathing again, because there might be like a lump in the throat area, sometimes a persistent cough or changes in your voice, such as hoarseness. If you've ever been on any of our webinars before too, you know, anytime I talk about symptoms related to cancers, I like to point out that many of these symptoms can be associated with other conditions that are less serious or potentially cancerous. So having one or more of these symptoms does not mean that you have thyroid cancer, but worth a check-in with your physician if you are having any of these symptoms. Okay, moving on to talk about what causes thyroid cancer. What are those factors that could increase a person's chance to develop thyroid cancer in their lifetime? When we talk about risk factors for any medical condition, always important to remember that typically it's not one particular risk factor that causes a person to develop that condition, in this case, thyroid cancer. It can be a combination of different factors listed here, or perhaps other factors that we don't even know about that could have caused a person to have higher thyroid cancer risk. The main risks, though, that we do know that are associated with a higher chance to develop thyroid cancer are things like radiation exposure in childhood. So this is referring more to if somebody had radiation treatment to their head or their neck for a medical condition during childhood, or even obviously very rare, but if somebody was exposed to a nuclear accident like Chernobyl, that level of radiation can increase risk. Very important to remember, we are not talking about the type of radiation that results from everyday medical imaging like a dental x-ray. We also know that being female, having a higher BMI can increase thyroid cancer risks. And again, we'll get to this much later on, but having a family history of thyroid cancer or other related cancers can increase a person's chances of developing that type of cancer. Important to remember, there's really no screening that's done in the general population like mammograms or colonoscopy that's recommended for everyone. That's not typically done for thyroid cancer. Usually an evaluation is started if somebody's having symptoms or if there's some reason to suspect that they could have a growth on their thyroid. Ultrasound is usually the first step, where they use a wand that they put over your neck that creates a picture on a screen, similar to the kind of ultrasound that you would get if you were pregnant, to look at the thyroid gland to see if there are any growths on it. If there is something that the doctor finds concerning, that can be biopsied, which is basically using a needle to take a small sample of whatever that growth is. Good news is that only about 5 to 15% of growths that are biopsied from the thyroid turn out to be cancer. As I mentioned earlier, blood tests aren't necessarily that helpful because standard thyroid hormones usually are normal. Things like CT scans, MRIs usually are not used at the beginning as a first line in the diagnosis. Again, ultrasound is typically used first, but if somebody has a confirmed thyroid diagnosis, those other screening modalities might be used to help further characterize the cancer and the tumor itself. Okay, we are changing gears to a completely different part of the body now. These are the adrenal glands. So we each have 2 adrenal glands. One sits on top of each kidney. So these are very small glands, but they're powerful, small but mighty. So they produce hormones that help regulate blood pressure, blood sugar, metabolism, our immune functioning, our body's response to stress, as well as certain sex hormones. So again, there are pretty big players in our body, even though they're small. It's important to remember too, as we get into the different types of tumors we can see in the adrenal glands, that there are 2 different parts to each adrenal gland. There's the cortex and there's the medulla. So just keep that in the back of your mind when we talk about the growths that we can see in the adrenal gland. I loved this word when I was researching to do this talk. I came across the word incidentaloma, which I thought was kind of humorous. So basically, incidentaloma means that most of the time, these are growths that are found incidentally. So it's actually very common for people to have adrenal tumors that they know nothing about. They're found very commonly, usually by accident or incidentally, when somebody is having a CT scan or an MR scan for another reason. If one of these tumors is found, though, there's usually 2 very important questions that need to be addressed that gives us a better idea of how these should be handled. First, is it cancer or not? And second, is it producing too much hormone? Very important for those 2 questions to be addressed to give the physician a better idea of how these should be treated. The other thing I like to mention, just because we talk about family history and being aware of the cancers in your family, is interestingly enough, the adrenal glands are actually a pretty common place for other cancers to spread, particularly the kidney. So if you hear that somebody in your family had adrenal cancer, it's always important to distinguish, wait a minute, was that a cancer that started in the adrenals, or was this something like a kidney cancer that spread to the adrenals? Then that would be considered kidney cancer, not adrenal cancer. And that comes into play again when we're trying to decide if there's anything concerning in the family for an inherited endocrine condition. Okay, as I mentioned, there's the cortex and the medulla. So first I wanted to talk about tumors or growths that we can see in the cortex part of the adrenal gland. Fortunately, you can see from the top three, most times anything seen in the adrenal gland is benign, small, they don't really cause problems or produce extra hormones. The one exception that we do have concerns about when we see in the adrenal gland is something called adrenal cortical carcinoma. So that's a cancer within the cortex part of the adrenal glands. Fortunately, it's rare. Unfortunately, it's pretty aggressive. And most of these do produce excess hormones, so could have symptoms associated with them, depending on which hormones are produced in excess. When we talk about the medulla part, so the other part of the cortex, there are two types of tumors that we can see, or that we focus on. First, and I challenge you to say this 5 times fast, is a pheochromocytoma. So this is a tumor that produces excess adrenaline and noradrenaline, which are our body's stress hormones. So having a pheochromocytoma can cause pretty significant, sudden, severe symptoms like very high blood pressure, rapid heart rate, headaches, sweating, anxiety. What's interesting about pheochromocytoma is that 30 to 40% of the time, they are associated with an inherited condition. Again, we'll talk about those later. Within the cortex, or I'm sorry, the medulla of the adrenal gland, we can also see neuroblastomas. Typically, those are childhood tumors, and they range in their severity from something that resolves on their own to being a very aggressive cancer. Okay. Symptoms of adrenal cancers. Tumors. I don't want to focus too much. As you can see, there's a lot of information on here. Really, just what I want to point out is 75% of the time, adrenal tumors do not produce excess hormones and do not produce significant symptoms. But if they are producing symptoms, it really depends on which hormone is being produced in excess. So you can see on the left, depending on which hormone is being made, or there's more of it circulating than there should be, can lead to specific symptoms that a person might be experiencing. Okay. As far as risks for adrenal cancers, smoking and tobacco use, diabetes and high blood pressure, again, are known risk factors leading to adrenal cancer. Also having a higher BMI, and of course, a family history of adrenal tumors or other related cancers can increase a person's risk for the development of those tumors. Just like the thyroid cancer that we talked about, there's no routine screening that's done for adrenal tumors. If one is suspected, or as I mentioned, a lot of times they're just found on imaging to begin with, by accident. But if they are suspected, imaging first, typically with a CT scan, would be the first step. And then, as we talked about, it's really important for physicians to classify these tumors as to whether or not they're making excess hormones. That can usually be done through blood and urine testing. Biopsy is actually rarely needed to confirm the diagnosis of these tumors. Okay, switching gears, we are moving right along to the parathyroid. So you can see in this picture, the parathyroid are those 4 little yellow glands that sit kind of on the underside of what looks like the butterfly. So they kind of face in or face your neck. So the parathyroid glands, their job is to regulate calcium levels in the body. Just like we've talked about in the other glands, most parathyroid tumors are benign, but they can produce too much parathyroid hormone, which is, easy to detect by higher calcium levels in the body. About 80 to 85% of the time, a parathyroid tumor is going to be a parathyroid adenoma. What's interesting is because of it's only calcium that is created at a higher level if there is a tumor that's overproducing hormones. It's pretty interesting to see that there's a very specific constellation of syndromes versus the other, like the adrenal glands that we were talking about, that it really depended on which hormone was being overproduced as far as what problems it could cause. With parathyroid tumors, we tend to see sort of one constellation of symptoms. And the phrase that's often used to remember what those are is bones, stones, groans, and moans. So things like bone pain, kidney stones, digestive problems, fatigue, changes in mood and memory, that all can stem from having too much calcium in the body, circulating through the body. And we made it to the last gland that we're going to talk about, which is the pituitary gland. You can see from this picture, it sits at the base of the brain. And this is actually called the master gland because it kind of controls what everybody else is doing. So it secretes hormones that control the other glands, telling the other glands when they should be secreting hormones. Fortunately, just like, I feel like a broken record, and I apologize that I keep saying this all over or over and over again, but remember that almost all of these tumors are going to be benign as well. Within the pituitary gland, though, there are some tumors that produce too much hormone, um, and that could cause symptoms. Again, rarely we see that, but it could if there's too much tumor or too much hormone produced. The other way a pituitary tumor could cause problems or symptoms would be if it's large enough that it's pressing on nearby structures. So remember, this is at the base of our brain. So having a tumor that's at the base of the brain can cause things like headaches or vision changes. So it's not a brain tumor itself, but it's pressing on the nearby structures. Okay. So that was our overview of the endocrine system, the 4 main endocrine glands that we wanted to talk about today, as well as tumors that are seen or growths that are seen in those glands. So as I promised you, we were going to end with a discussion about genetics and hereditary endocrine tumors. So let's start that off just by talking about just a little bit of background about what genes are and mutations, so that you have a better understanding of how that can play into the chances of developing one of these endocrine related problems. So as you all may know, a gene is a piece of DNA that gives our body information on how to do a specific job. And they are the basic units of heredity, meaning they're passed down to us, passed down from parent to child. A mutation in the gene is kind of like a typo or a mistake in that gene that makes the body really unable to understand what it's supposed to be doing. So if there's a mutation in a gene, that means that the gene just can't work properly and the body can't get the instruction on what it's supposed to, what job it's supposed to be doing to make sure everything's functioning right. Mutation, just like genes are passed down from a parent to a child, if a parent has a mutation, that can also get passed down from a parent to a child. Just remember, a healthy gene creates a healthy functioning protein, and the protein is the thing that carries out the job in the body. A mutated gene creates no protein or a non-functioning protein, and that's when we see problems. Please don't be overwhelmed by this. I think I was overwhelmed by it when I first saw it. But this is a list of all the different genes and syndromes that we know can result in problems in the endocrine system, including endocrine tumors, both benign and cancerous, as well as, interestingly, cancers in other parts of the body that are not within the endocrine system. There is a lot listed here. It's a very busy slide. I just wanted to point out a couple of these syndromes since we did focus on some of these cancers and tumors related to them. First, I wanted to talk about MEN. You can see there's MEN2A and 2B listed on here. Those are caused by mutations in the RET gene. And the important thing to remember about MEN2 is that this is associated with higher risk for medullary thyroid cancer, as well as pheochromocytoma, which are those tumors that cause the production of excess stress hormones. We also did talk about adrenal cortical carcinoma today. So remember, that was the one tumor of the adrenal glands that we see that can be cancerous, that can be aggressive. And that's associated with Li-Fraumeni syndrome caused by mutations in the p53 gene. With Li-Fraumeni syndrome, actually, adrenal cortical cancer isn't even the main clue that we might be seeing Li-Fraumeni in a family. We tend to see other cancers as well, including sarcomas, breast cancers, brain cancers, leukemias, again, going along with the adrenal cortical carcinoma. I also wanted to quickly point out VHL because this is another syndrome where we see those pheochromocytomas that we talked about. We can also see renal cell carcinomas or kidney cancers in the same families where we're seeing the pheochromocytoma. We can see neuroendocrine tumors, paraganglioma. Interestingly, too, one of the hallmark features of VHL that is not related to the endocrine system are things called hemangioblastomas, which are basically tumors of blood vessels. So again, this is a very comprehensive list. I just wanted to focus on a few since we talked about those growths today. All right. So now that we talked about some of these syndromes, again, you might be asking yourself, well, how do I know if there's anything in my family that I should be concerned about? How do I know if my family should consider a genetics evaluation for one of these syndromes? And there are a couple clues that we can see in a family tree that might raise some flags that a genetics evaluation could be helpful. First, if we see one person who's had multiple endocrine tumors, so somebody who's developed different, either benign or cancerous tumors of the endocrine system over time. Bilateral tumors, typically impaired organs. So in this case, adrenal glands, if we see tumors in both sides of the adrenal gland, that could be an indication that there's a genetic problem. If we're seeing rare tumors, remember those ones that we've discussed, the medullary thyroid cancer, pheochromocytoma, adrenal cortical carcinoma. So not your garden variety cancers that we can see pretty commonly in the general population. If we see more than one person in the same family who's had the same or related endocrine tumors, especially if we're seeing it in more than one generation. Just as genes are passed down through the family and mutations are passed down through the family, if we're seeing a pattern of tumors that looks like it's being passed down through the family, that could be an indication. And as I mentioned, although we were focusing on endocrine tumors today, some of these syndromes do have other types of cancers that can be associated with them. Lastly, I wanted to point out sudden young deaths. I know it might not seem like it fits in here, but sudden young deaths can happen for many different reasons, like a cardiac problem, embolism, or an aneurysm. But we can also see sudden young death happen as a result of a pheochromocytoma. So if a sudden young death is reported in the family, that might be, something to consider looking a little further into. Okay. Now we can talk a little bit more about how genetic testing works. So if there is concern that there's an inherited syndrome in the family, how can we test for that to see if there is? And that's really just done by looking at somebody's genes. So genetic testing is proofreading genes to look for mutations that can increase risks. So we're looking to see if the gene code looks like it should, or if there's a mutation in one of these genes. It's done fairly easily by either a blood or saliva sample typically. Um, and now we can look at many different genes at one time. So that chart that I showed you before, we can test for every single one of those genes just from one sample. Important to remember, although not always possible, the testing is most informative if started with a family member who's been affected with one of these endocrine tumors. Sometimes that's not possible, but that's the more ideal situation. I always like to point out too that genetics is a family affair. So if a person has a mutation, it doesn't just pertain to them, it's information that impacts their family members too. All first degree relatives of that person would have a 50% chance of having that same mutation. And then other family members have a chance of having the mutation as well. Their chances depends on how closely related they are to the individual where we found the mutation. Okay, now we're going to play a fun game. Jillian, I don't remember do you bring it up now in the chat or do I talk first?
I'll go ahead and launch it in the chat.
Okay, so we're going to play a fun game where we're going to test the 3 minutes of knowledge I gave you of these inherited syndromes. We don't expect anybody to get these right. It's just a good illustration to learn a little bit more about these inherited syndromes. So I made these up. Any family that, represents a family that you might know, it's purely coincidental. Like they always say at the end of Star Wars or all of those movies, this is purely coincidental. It does not represent real life. So this is what's called a pedigree or a picture of a family tree. And this is what people like me, genetic counselors, use to see if there's any pattern in a family that could suggest an inherited problem. In this case, we're looking at a family who has a history of some endocrine related growths. You see circles for females, squares for males, lines between people show that they're siblings or brothers and sisters, and lines going up and down show that they're parents. We have an arrow pointing to the person in green because that's the person we're talking to today. Anybody who has a colored symbol means that they've been diagnosed with some sort of cancer or tumor. So in this case, we have a 30-year-old. Oh, I should tell you what we're going to do is go through the pedigree, and then Jillian's going to put up the name of 3 of these genetic conditions, and you get to guess which one is in this family. Okay. So in this family, the first one, we see a 30-year-old woman who was diagnosed with a pheochromocytoma at 25 years of age. Because of her family history background, she did have preventative removal of her thyroid at 8 years of age. And if you go up a generation in the family, you can see why. Her mother was diagnosed with medullary thyroid cancer at 35 years of age, and her mother's sister, who is currently 48, was diagnosed with that same cancer at 32 years of age. On the patient's mother's side of the family, we see just one uncle with prostate cancer. So Jillian, I don't know if you have the thing pulled up yet.
Yep, it's up and it's available for everyone to respond in the chat. We have a few responses coming in. So I think we've got a few more minutes for few more seconds for everybody to put theirs in.
I think we're actually doing pretty well on time.
Mm-hmm. Okay, there's still responses coming in. All right, it looks like we've stabilized out. 62% of people responded MEN2, and about 38% of people thought it might be MEN1.
Perfect. I'm proud of you all. That's it is MEN2 caused by mutations in the RET gene. And let me tell you, sometimes I still have to look up MEN1 versus MEN2. So the fact that you all got that on your first try was very impressive. If you're ready, we can move on to number 2.
Yep, go ahead.
Okay. So in this made up scenario, we unfortunately see a 5-year-old little guy who was diagnosed with an adrenal cortical carcinoma last year at the age of 4. Looking further into his family history, you can see his mother, who is in green, was diagnosed with breast cancer at 32 years of age. Mom has 2 siblings, one of whom is a 40-year-old brother who's alive, doing well, but she unfortunately, had a sister who passed away at 42 years of age with a history of 2 different types of cancers. She had an osteosarcoma, which is a type of bone cancer at 12 years of age, and then years later developed a breast cancer. We can also see that the child's maternal grandfather, so mom's father, who's colored in brown, passed away at a young age of a glioblastoma, which is a brain tumor. On the patient's dad's side of the family, we do see that a grandfather, dad's father, was diagnosed with colon cancer at 65 years of age.
All right, are you ready for me to launch?
Yep.
Okay, everybody should be able to see that now in your chat. All right, Julie, we've got responses coming in. Give just a few more seconds for a few people.
Okay.
Okay, so it looks like overwhelmingly the answer is LFS, a few votes for Cowden, and a vote for none of these.
Okay, great. Another good job. So yes, this is Li-Fraumeni syndrome, which is associated with mutations in the P53 gene. TP53. All right. And we're going to move on. Oh, go
Julie,
ahead.
what about that family history, makes you think about Li-Fraumeni syndrome in particular, given that the breast cancer's in there?
Right. So Li-Fraumeni, as I kind of mentioned very quickly when we were looking at that chart, is not typically one that comes to mind right away when we think about inherited endocrine tumors. Li-Fraumeni is one where we see almost a 90% cancer risk in a person's lifetime. And for women, the most common cancer would be early onset breast cancer. Sarcomas are also a hallmark of Li-Fraumeni. So seeing that breast cancer and the sarcoma in combination with the adrenal cortical carcinoma is pretty representative of Li-Fraumeni.
Okay, great. Thank you.
I think I have time for the last one.
Yep.
Okay. So this is the third one. This is a bigger family. I'll try to go through it quickly now that you all are pretty well oriented to what a pedigree looks like. So in this situation, we have an 18-year-old young man who was diagnosed with a retinal hemangioblastoma at 16. So that is a tumor of blood vessels within the eye that was diagnosed at 16 years of age. If we go up a generation, we can see that his mother has had a couple complications. First, she had a kidney cancer, a renal cell carcinoma at 36. She also had one of those hemangioblastomas, but it was in her brain, not in her retina. Mom has one 48-year-old sister who's alive and doing great. She also has a brother who's had two retinal hemangioblastomas, another brother who's had a pheochromocytoma. And then again, go up one more generation, we see grandpa. Mom's father has also had a renal cell carcinoma and a pheochromocytoma. On the patient's father's side of the family, we do see dad's sister or his aunt has had papillary thyroid cancer.
All right, I'm going to go ahead and launch the poll. Okay, we've got a few responses in. We're just waiting for a few more people. All right, so it looks like almost everybody said VHL.
Good job. 3 for 3, so that's right. This is von Hippel-Lindau syndrome caused by mutations in the VHL gene. One thing I did want to point out, I threw in that papillary thyroid cancer kind of as a red herring for you all to remind you that papillary thyroid cancer is very common and it is seen not uncommonly in young women. So many of you might have somebody in your family who's had a papillary thyroid cancer, which would not be as concerning for one of these inherited syndromes. When we're talking about thyroid cancer, the medullary type is the type that typically causes concern. So I thought maybe I could trick you, but I guess I didn't. Um, so I am done. I am going to now switch things over, hand the mic over to Kelly Nickelbein, our program director, to talk to you more about the IMPACT program.
Great, thank you, Julie. And while I'm talking about the IMPACT program, I encourage you all to put questions in the Q&A, and we will cover those as soon as I am done talking about the IMPACT program, which will only take a few minutes. All right, Julie, you can go ahead and move the slide forward. And as Jillian mentioned in the beginning, I am the IMPACT program leader and also a navigator for the program, along with Julie Goldstein and Jillian Sotelo. The three of us are, like I said, navigators, and our role is to be a single point of contact for anyone that comes into the program that either has a cancer diagnosis or a questionable tumor, or is concerned about their risk of cancer based on personal or family history. So essentially what we do is we try to make the process from diagnosis and beyond a little bit smoother and connect the dots between all of the internal benefit programs that Thermo Fisher offers, in addition to coordinating and identifying any external resources that we are aware of and have accumulated over the 10 years that we've been with Thermo Fisher. So some examples of the additional services would be things like expert medical second opinions. We have a virtual second opinion service, connecting with our mental health benefits like Spring Health. Certainly, we can act as a go-between with our medical insurance providers like United Healthcare. We also connect with the Cancer Support Program with United Healthcare as well. And in addition to that, because we are genetic counselors, we can certainly provide genetics education and counseling to individuals that might be concerned about their family history and coordinate testing in most of the United States. It is a voluntary program, so anyone that is interested in using it, it is free, but also completely voluntary. In order to be eligible for the program, in the US, you need to be on a Thermo Fisher medical plan. I already mentioned United Healthcare, but we also have our others like UPMC and Kaiser and a few of the other sort of local programs or local carriers. Anyone who's on it, meaning an employee, a spouse, domestic partner, or dependent children. Again, you don't have to have a cancer diagnosis. You could either have a past diagnosis or just be concerned based on family history. We are available with some select services for employees and their dependents that are located in the UK and also in Canada. All right, next slide, Julie. If you are interested or have more questions about the IMPACT program, please email us at impact@thermofisher.com. This is where you will go if you would like to request an enrollment form or, like I said, ask more questions. Once we receive that email, you don't need to provide any kind of personal information, just your name and an email address. What happens from there is it will trigger an electronic enrollment form to be sent to you. At that point, once you fill that out, then I will provide you with an introduction email in addition to who your navigator will be and what the next steps are to schedule. So please, if you're interested, please email us at this email address. And I did see in the chat that someone asked about our roles as a navigator, and hopefully I answered that question. Yes, we do provide education to the company by way of these webinars. We also have newsletters that we put out in addition to Viva Engaged posts that we do monthly. But we are also very much advocates for employees and any participant that comes into the program. So we can be that go-between with the health insurers. We certainly work with their representatives and try to help solve problems and manage issues as best we can. Same goes for, like I said, any of our other benefits that Thermo Fisher offers. So hopefully that answers that question. And with that, I'm going to actually turn it over to Jillian to moderate any other questions that have come in. And like I said, please get any other questions in there or send us an email separately.
Thank you so much, Julie and Kelly. Guys, you have one of two options to submit questions. There is the Q&A option. You also can submit anonymous questions there, or you can pop them into the chat. So there was a question that came up that I think I'm going to go ahead and answer. And it was really a question about how the pituitary tumor can cause secondary failure in the thyroid. So I think keeping in mind that we are not physicians, but also just the anatomy of where the thyroid hormones come from. Kelly mentioned that the pituitary gland is really the master gland. And the pituitary gland typically regulates the thyroid by releasing a hormone called TSH. So a tumor can get large. Usually they're benign. They're called adenomas, but they can get pretty large and they can actually press on and destroy all of the healthy surrounding pituitary tissue. When that happens, the pituitary is no longer able to release the hormone TSH. And at that point, the healthy thyroid gland isn't getting any instructions. It's not getting any of the TSH levels from the pituitary, and then is not itself able to produce the thyroid hormones, which are T3 and T4. So that can result in a thyroid fail or slowdown not because the thyroid itself isn't working, but because the pituitary gland, the healthy tissues of the pituitary gland are not able to release the necessary hormones to stimulate it. So I hope that answered the question that was in there. That's a really good one. So I think that will give us some more information there. And then I think another question that is frequently asked is, Julie, knowing that thyroid cancer is so common, what would be some of the things that, and knowing that so many people are young, what would be some of the things that, might lead you to think about inherited genetic testing?
Oops, sorry, I was still on mute. For inherited testing related to thyroid cancer?
Yeah.
First and foremost is the type of thyroid cancer. So as I mentioned, papillary thyroid cancer is what you're going to see 85% of the time in typically sporadic thyroid cancers. What's more concerning from an inherited standpoint is if we see the medullary type of thyroid cancer. So 25% of the time, even regardless of family history, if somebody has medullary thyroid cancer, that is worthy of genetic testing. Then again, also if we see some of the other tumors that can be related or seen in syndromes like MEN, for example, where we can see tumors like pheochromocytomas or other growths, not necessarily thyroid cancer, but that can be seen in conjunction with inherited tumors.
Okay. Yeah, I think that that's such a good point to really pay attention to the type of thyroid cancer it is, it seems like.
Yes.
Okay, I don't see any more questions coming in at this point. I'd like to thank you both,
Jillian,
really. Yeah, go ahead.
Oh, hang on. Yeah, I just want to cover I want to just mention briefly about the question around our privacy policies, and anyone who would like to take a look at our enrollment form or consent form where these are detailed, please send us an email and I'll certainly get that your way so you can look at them in detail. But just, in summary, the impact program, even though we are internal Thermo Fisher employees, the 3 navigators, we're pretty siloed off. So anything that comes in terms of medical information and data is kept extremely confidential within the navigators, with the exception of anyone that you would like us to work with on your behalf. So someone had mentioned, do you advocate with the health insurers? Well, we can, but we would need your permission to contact them and speak about your your questions. And so that is detailed in our consent form. So anyone who would like to review that, like I said, please just send us an email and we'll get that your way so you can take a look and ask questions from there.
Such a great point. And Kelly, just as a reminder, people can email impact@thermofisher.com.
Yes, impact@thermofisher.com. If you have any specific questions for any of the 3 of us, our 3 personal emails are here, although some of us have some challenging last names to spell, so if you can't remember them, impact@thermofisher.com comes to the 3 of us all together. So that's really your best route to make sure that you get a timely response.
Okay, and I went ahead and put that in the chat as well in case anyone needs it. Just as a reminder to everybody, thank you for attending. This webinar was recorded and it will be posted in our Impact Cancer Care CSC site. The link for that is at the very top of the chat. Please look forward to future webinars from us. And as Kelly said, if you have any questions, feel free to reach out. Thank you so much for attending today and enjoy the rest of your afternoon.